So I wanted to start the recording because this is kind of important in case Julie has to watch a little bit of the beginning. But, you know, so one of the DNP essentials is your ability to advise and assess and critique quality improvement. So definitely actively listen to your peers and provide them with ideas and feedback, not just like, yay, you're doing awesome, but constructive feedback, because we all benefit from hearing constructive feedback, right? And in case you're feeling like, oh, I always hate getting feedback because I've been traumatized by it in the past, you know, I feel like you guys have been with each other for a term. We've established we're a pretty friendly group of people. But, you know, if you're not that good at giving feedback, one of the things to remember is that you're going to, you know, sandwich it, like give good feedback and then say, you know, one thing you might want to try. You know, we're not here to like hammer people and beat them down. We're here to help them and encourage and come up with some new and creative ideas and be leaders in the field of nursing. So what we'll do is we'll first start with a check-in, okay, and see how everyone's doing. And then we'll dive into sharing a run chart that you're first, your name, your topic, a run chart that you are feeling it looks really good and is going as you would like it to, and one that you would like some feedback about or some additional advice about. Okay, so any questions about that?
Just right. about the sessions. Oh, do we do reflections after each one? I was kind of reading through the assignments, or is that just after the final?
No, it's at the end. It's at
okay,
the end.
So keep good notes.
Yeah, and we won't be giving feedback as people are presenting. We'll have everyone present, and then we'll look for kind of like common themes and things to touch on. Because usually a lot of the things people are experiencing occur across the several different sites, okay? So does anybody want to go first?
I will. Nobody else wants to.
Okay, go for it.
Okay, let's see. So let me share my screen here. And I'm sharing a run chart that I feel good about and a run chart that I have questions about, right? Okay, yes. Perfect. So I had them pulled up. Let's see if they're still working here. Okay, so I'm just going to start off with the one that I feel good. Well, no, I feel probably the best about my my process, probably my process, my B process. It's probably the run chart I feel the best about, because I think that it'll be fairly easy to track as far as use of it, because it'll go out with the new OB patient visits in clinic today. We already identified a few things that we already need to change up even after the first day, and we only had a couple new OB visits today. So I thought that was good about like where we kept it and how we gave it to them. But I think that B outcome is going to be a little bit harder, because keeping track of the patient tool, the satisfaction tools, or the patient surveys, and getting them to the patients and back from the patients, I think we maybe need to involve the MAs and receptionists a little bit more than I thought. So I'm feeling pretty good about that process, and I'm also feeling really pretty good about huddles that went really well today. Just some maybe things to change up, and maybe we need to huddle at the beginning of the day and then before we start our afternoon, because sometimes we can't work through all the patients. We'll just kind of have to see how that process goes. But I feel like the huddle tool, I feel like it worked well today. But, you know, it's just the first day, so I feel pretty good about how that process is going. However, C, the clinical decision-making tool, tracking use of it will be okay. But what I'm really concerned about is my C outcome just doesn't seem, I don't know if I'm not tracking it right, because what I want to find out with my C outcome is, so how I have it set up now is the percent of positive screenings over the number of patient screened. But I think it needs to be the percent of positive screenings over the number that should have been positive. Because like when we use our clinical decision-making tool and you look at the patient data, are we catching it? Are we catching that they should have been positive? And then the other thing, so see, I've just got all kinds of issues here, is my C, oh, that's not what I want to do. Oh,
Can
sorry.
you go back to that other one real quick, just so I can see what you're?
Oh, I'm sorry. I don't know what all these noises are. This C, yes, I can. My outcome for C.
Mm-hmm. And what are you saying you think it should be?
So right now it just says it's percent screening positive, but over like the number that are screened. So that's how we're going to get that, the percent, the ones that screen positive over the number that are screened. But what we're missing is we're not identifying those that should have screened positive. So should it be like the ones that like we miss people, I guess is what I'm saying. So should it be like, because not everybody obviously is going to screen positive, and we don't want a huge number to screen positive because that would be bad. But the thing is, like, we're missing people at the very basic step, which is BMI. And then we just miss them all together if we don't catch that. So what I'm wondering is, like, the clinical decision-making tools to help us to look at the patient demographics and be like, okay, so this patient's BMI is high, and then they have XYZ risk factors. So they should screen positive, but then nobody identified that they actually did screen positive. So what I'm saying is it should be over the number that we actually identified over the number that should have been identified.
What's your process?
My process is that we use the clinical decision-making tool, which would be how we would figure out the screen positive.
Does that include BMI?
The process. Well, the clinical decision-making tool is I can pull it up. It's the flow chart that has like, you know, is your BMI greater than 25, and then yes or no. And
is it for providers or patients?
The clinical decision-making tool is for providers, so we recognize that, yes.
So it's asking, okay. And so you're worried that they're not using that tool correctly.
Yeah, and I'm worried that the reason I made the tool is because we were missing the piece of identifying who actually screened positive based on their personal risk factors.
So your tool should be designed to prevent that. Do you think it does that?
To prevent missing people?
Mm-hmm.
Well, I'm hoping so. That's why I thought that would be my outcome, because that's what I'm trying to do, is implement the tool so we don't miss people.
Right. So do you guys see here how she was looking at her outcome and thinking, oh, but what if we're missing people? And that's not an outcome issue. That's a process issue. Does that make sense? Okay. So now you need to look at, if you're worried about missing people, you need to look at your process, and is your process good enough to be capturing the people it should be? So for example, I'm trying to say this so it's not confusing. Okay, so pull up your tool, your process tool. I know I said we'd give feedback after, but I can't resist.
It's okay. It's okay. Somewhere it's open down here. Let's see. There we go. Let me make it bigger here.
All right. So what is a potential improvement that could be made to this? Like, well, first of all, let me ask you this. How do you know this is being used?
How do I know it's being used? Because we're charting it and tracking it.
So how are they charting that this is used?
Well, like for each patient, there's just a stack laying there, and then they can circle the positive risk factors and leave them for me to look at. So I should have the same number of new OB patients that I have tools used.
So let me just ask this more clearly.
I'm sorry, I can't hear you.
Did this? How am I supposed to use it? What do you?
I couldn't hear you. I apologize.
Oh, let me turn off my video. If I'm a provider in your clinic and you hand this to me and I'm new, what do you tell me in terms of how I'm supposed to use this?
Okay, so you've seen your patient and you've went over the shared decision-making tool with them, which has all the personal risk factors on it. So you guys have went through those to see if there are any, and the BMI is on there for you too, on the shared decision-making tool. So you've seen your patient, you've taken your notes, you come back to see if they need an early glucose tolerance test.
Mhm.
So the first thing you do is your BMI is written right there. So first of all, is their BMI greater than 25? And then if it's not, you're done. And then if your BMI is greater than 25, are they positive for the risk factors? And then if
But what
they're
am I
not,
supposed to do? Do I mark this? Do I just think it in
you
my
can
head?
you can circle on it, you can write on it, whatever works for each provider. But
Okay,
then
no,
what
no,
you
no.
do,
Like you need to
no.
have a methodology so that people aren't making stuff up. Like you need to be like, you need to circle yes or no.
Okay.
Because like what's so hard about circling yes or no, right? Like
Nothing.
that's
Yeah.
way
No, nothing.
easier than writing it. So they
Yeah.
circle it and then
Mhm.
so I would just tell people to circle. Show me that
Okay.
you've gone through the algorithm.
Okay.
Because
Okay.
if they're circling, then you know that they're going through the algorithm, right?
Uh-huh.
If you're just saying, hey, write whatever,
Mm-hmm.
you don't know if they're actually looking at, but like if they have to circle yes or no, that means they have to look at their BMI.
Mm-hmm. And
Because
then that's one of
you're worried that they're not looking at BMI and they're supposed to be, right?
and then I'm worried they're not screening for the risk factors. We're
Right.
just
So
missing people.
then
Yeah.
they have to circle. Because here's the thing, you
Okay.
guys, right? Like you can't just hand people stuff. You have to show that it's being utilized. And I noticed
Mm-hmm.
that you did this in your B process. Go to your B process run chart.
B process.
So what do you have on your what is it? The y-axis there.
Percent of patients receiving shared decision-making tools.
Yeah, like who cares if they received it, right?
Uh-huh.
Are they using it? So percent of patients utilizing shared decision-making tools. Because if you
Okay.
hand out 10 of them and they don't get filled out, you shouldn't be getting 100%.
Gotcha. Oh, shoot. Gotcha.
Okay?
Okay. Yep.
All right. Thank you.
So then my C outcome is still percent positive screening.
Yeah, because like and then my question to you is why do you have 75% on there? Like are 75% of people supposed to be having high risk factors for pre-gestational diabetes or gestational diabetes?
No, see, that's why I was confused because I just want to make sure that we're catching the ones that should have screened positive. Like, are we using, like, when we
Right.
do the clinical
So you need
decision-making
to
tool?
so for your goal for C
Mm-hmm.
outcome,
Mm-hmm.
you need to do the research and Google what percent of patients should be screening positive. And that's your
Okay.
goal.
Gotcha. That's where I was confused.
Yeah, because like and then you also have to look at your patient population. Like one of your peers has a project in a clinic that is largely Afro-Cuban population. Like they're going to have different risks than like, little Scottish clinic or something, right?
Mm-hmm. Right.
So you need to look at your population and Google, it shouldn't be that hard, like what percentage of pregnant white middle-class women screen positive for GDM risk factors or something like that, right?
Mm-hmm.
And that's your goal. You don't,
Okay.
because you don't want 75% screening positive for high risk. Ooh,
I think though in
but
our
that
population,
might be it.
it's probably higher than that, to be honest with you.
Right. Yeah, so
Because
check.
I think out of the 12 to 16 week patients I saw today that should have had early GTT, I think I saw 4, and I think I did it on all 4 of
And
them.
just be really clear, screening positive for what? Like high BMI or screening positive for risk factors? Like what does that mean?
Screen
Like,
positive. Screen positive would indicate that they need an early GTT, and that would be a BMI and one other risk factor.
great. Okay, just so that that's clear to your whoever's filling this out and to the providers and whatnot. Okay.
Yep, gotcha. Okay,
Cool.
that's much more clear. I was so lost. Thank you.
Awesome, awesome. That's why we have these.
And then my
Okay,
other, can I ask more
go ahead.
questions on D?
Yeah.
Okay, so on D on my, can I just pull up my case management log? I am concerned about, where is it? It's open down here somewhere. I am concerned about, okay, so when I do that. I'm okay with tracking BMI. I'm okay with personal risk factors. I'm okay with the labs. I'm good with the positive screens. I'm good with the plan. I'm good with ordering. It's beyond that that the first 3 weeks, because usually they come to see us around 8 weeks. So usually we don't screen till 12 to 16 weeks. So for the first 3 weeks, I can go back to see if we actually got it completed or resulted and if they needed follow-up testing. But after that, I won't be able to because we'll be done before I can track those patients.
So when you have a longitudinal type of data collection where follow-ups extend for several weeks, then you need to include all of the previous data with each PDSA cycle because the scores will improve over time. Like at first they'll be low, but as you start doing that follow-up over time, even through successive PDSA cycles, the overall score will improve. Does that make sense?
It does, but then like I'm only the score won't improve. Well, I guess what I'm saying is I won't be able to track like, okay, so like our new OBs today. I won't be able to track if we completed it or resulted or if they needed follow-up testing for 4 more weeks when they come back.
Yeah, that's fine.
Okay, so then I'll just go back. So then I'll just have 3 weeks worth it. So then the data for my earlier cycles will actually look better than the data for my
Yeah,
last
but
cycles.
each PDSA cycle, you're still getting average scores. So PDSA 1 will have low average scores for this because you haven't been able to do any follow-up, right?
Mm-hmm.
And then
Because the score stays cumulative. So like
right.
when I go back to enter this, and then my other question was, so like my patients that I saw that were 12 and 16 weeks today, since we started today, do I track them? Or I just start tracking my new OBs today? Do I retrospectively track the ones
Yeah, I
before?
would. And then you
Okay.
just put not applicable for the new OB part.
For the actual screening part, because we hadn't started that process yet. But I can just go ahead and see if we had done it based on
Well, shouldn't they still get screened
they,
even though they're not at a new OB?
well, yeah, I mean, if we didn't catch it at their new OB, like the ones today we had all caught, fortunately.
Yeah, so you could look at it in retrospect.
Okay. So go
Um,
ahead and start picking up each week
I
my
would
ones that are
because
coming back.
you need to screen them if they weren't screened and start the whole process if that all
Okay.
was missed. Yeah.
Okay. I was just trying to make it make sense, but it's okay because this is cumulative. So as I go back in week like 5 and enter my testing from my
Yeah.
patients that were 8 weeks today and coming back for their 12-week visit and getting screened, the score will just go up because it'll
Yeah.
get better.
Yeah. And you should also include those 12 and 16 weekers because they will help your data. They'll give you some follow-up data for PDSA 1, right?
Okay. So just
Yeah.
go ahead and put that in there and see how we did with them.
Yeah.
Gotcha. Okay. So I don't know if that was applicable or applied to what we're talking about, but I'm just trying to figure it
Yeah.
all out.
Sounds good.
Okay. Thank you.
You're welcome. All right, Cynthia, you're up.
Hi, everybody. I have the thing that I think is going to be going better is the, oh wait, let me get my screen sharing up here for you. Okay. So this is my team engagement score. I haven't done my kickoff meeting, but the second set of surveys that when I re-administered that was a little bit better, and I was able to capture more of the providers. So this one I think is hopefully going to be doing better. And then the one that I have a question about, is, let's see, it's D. Oh, I'm having a hard time seeing it with the, Here we go. So I reran my CML, and I was really disappointed that it seems like a lot of people are using more antibiotics now. I don't know if it's because it's been such a long flu and cold viral season that we've been having, but their scores weren't very good for ordering antibiotics inappropriately. So that I found very interesting.
Yeah, and then you can start, you know, keeping track of that data, like, oh, how many influenza positives did we have? Because really, they still shouldn't be getting more antibiotics.
Right. Yeah. Right. I was really kind of shocked that, you know, because they know that, you know, the project is starting, and it seemed like inherently they should be, you know, being a little bit more.
Well, maybe your improvement will look even more amazing later.
Well, that's true. I was thinking that's true. It's going to help. So I ran it through twice, and it was a very good suggestion because there were a lot of kinks in it. So I can show you my aggregate sheet, because I did have a question about what you guys thought about that. So the bronchitis and sinusitis I lumped together. And then I have the acute otitis media and pharyngitis by themselves. So there's 4 indicators that are common between all of the CMLs, but then they each have their own indicators here, like the sinusitis and bronchitis. It seems like there's a lot of prescribing of steroids. So that was something I wanted to look at. But then I don't know if I like this one, the bronchitis, sinusitis, duration of signs and symptoms, because sometimes at 3 or 4 weeks, they may still not need an antibiotic. So I felt like that one, I wanted to throw it out there and see what you guys thought of that. One of the other things that I was concerned about was prescribing cold medications. You know, for instance, when I redid the CML, someone wrote a prescription for Sudafed for a pediatric patient. So I didn't know if I would be better off looking at something like that. I wanted to see what you guys thought about that.
Can you rephrase your question again? I just want to make sure I'm clear about what you're wanting feedback about.
Oh, sure. So for the bronchitis and sinusitis, they are both on this CML. So I have the 4 things: bronchitis, sinusitis, pharyngitis, and acute otitis media. So the first questions, if they documented clinical decision making, you know, if they did not prescribe antibiotics inappropriately. And then this one with the supportive care, I had to add, you know, was there greater than 2 suggestions, like a humidifier and tea or honey, you know, pushing fluids, things like that. And then the primary care follow-up and the steroids, which seem to be overused. But this one here, I just didn't like it that I'm asking, you know, were the signs and symptoms greater than 3 weeks, because actually they probably still don't need antibiotics. So I thought that was a little bit misleading. So I thought maybe I should just take that out and think of a different indicator.
What are you trying to measure here?
Well, my concept of it is that I'm trying to measure the holistic approach of right care when someone comes in with a viral syndrome, like a cough, a cold, that type of thing. And so I don't know, it seems like I just keep adding more things on to look at, but I didn't know if I should put like cold medications there or not.
It's almost like you need a separate one for the different Like either you need to simplify it or you need to have a separate one for each condition, right?
Rather than
Like,
lumping those two together.
well, I don't even see otitis on there. I don't see like why does bronchitis and sinusitis get a column but not otitis media?
Oh, they do. Let me just go to that.
No,
and I'll
I'm
show you
saying
that.
here, like why isn't it on here?
Oh, because I did separate sheets for
So
those.
you do have separate ones for each
Right.
one. Okay. So one of the things that I would suggest for this one is no antibiotics if not indicated. Because if they're indicated, they shouldn't get a point off
Right.
for
Right.
writing it. So you want to be really super clear, right? So no antibiotics if not indicated. The other one is the clinical decision aid tool was used. And how are you measuring if it's used or not?
So
Or is it that it's documented, like that their reasoning is documented?
exactly.
Oh,
Right.
okay, okay. And then the supportive care, the primary follow-up, no steroids if not indicated.
Right.
So if I were you, I'd just type that in there right now so you don't forget.
Or would
Okay.
you put steroids prescribed? Because I just think the no is confusing for me because I was looking down at your point system and I'm like, no steroids, no zero. Like that was confusing to me.
So so getting a point is a good thing according to this system.
Right.
So that's why she's saying no steroid.
Right.
So you should have no in there because of the way you're scoring it right now.
Right.
Yeah. So so it's no steroids prescribed if not indicated, and then a 1 is a good thing, right?
Right. Exactly.
And but I see what you're saying, Andrea. It's just two different ways of looking at it. Like for you in your brain, you might have phrased it differently and done it in a flip way, but they're both valid. Yeah.
Yeah, because I kind of had it the other way, and then when when you said to get the kinks out, when I went to add it up, I was like, wait a minute, I'm not getting the score that I wanted. So that's why.
And then, for sinusitis, like it's 10 days, right? Isn't that the guidelines for sinusitis? 10 days with a bunch of other positives?
Right, right. And so maybe I just need to do a different one, like for the
so this would be bronchitis if you're leaving 3 weeks in there.
Right.
Yeah. Yeah. So, and then, and so this is why average scores are so important, because she's going to be able to combine all of these different things for all the different conditions and still have an average score that reflects right care. And then what is missing here is that average score represented as a %. Okay, so Cynthia, for your final column, it should be that average score as a %. So right now, this first person has 2 out of 6, right?
Right.
And so 2 divided by 6 is point. So you have an average score of your average score. It's not really average score. It's the score. And this is scores. Like an average score is when you're adding stuff and dividing it. And you aren't like, you're not adding and dividing multiple people's scores here. But anyway, it's the score as a %, which will be 33%, right? So the score is 2 out of 6. So the score is like, 0.33, which is 33%. Yeah, because then you get to add your average score, and then you're going to have a total average score at the bottom going across. Does that make sense? You don't have to do it now, but you need to have like the total average right care score for bronchitis. And then you're going to have the total average right care score for sinusitis and the total right care score for otitis media. And then you get to add those all together and then create your PDSA average right care score. And that's what gets charted in your run charts, is all of them combined, okay?
Right. So that where I wrote average score, should that say mean?
I mean, it's like it's not even a mean, like it's just the score. Like that's like saying like if I scored 2 out of 10, my average score isn't 20%. My score is just my score.
Mm-hmm.
An average score is when you're adding a bunch of people's scores together and getting an average. So I would just say like, it's just score. So the sum is the score. It's not an average score yet. It's just the score. And then the average score is when you're adding everybody's together.
Okay.
Like, and when this would be an average score is if people are doing like a range of possibilities, like, oh, you get a 3 out of 5, or and then another item has a 2 out of 5. But this is essentially a binomial scoring system. They either get a 0 or a 1. So there's not going to be an average score. It's just a score.
Okay.
Now, when you add them all together, then you're going to get an average score.
But should I leave it like that with just score there?
Yep. Yeah.
Okay. Perfect.
And then score the percent. Yeah. And so, so I would follow your intuition about seeing if, like, you know, this is going to take a lot of sleuthing on your part, because the no steroids prescribed if not indicated, like you're basically doing chart reviews on every single thing, because you're going to be like, oh, like, were steroids indicated? Let me look, right?
Right. I know.
So it's kind of epic, but if you're into it, it would be, you know, it can still be valuable, but just be prepared for what you're entering into here. And you know, you guys, part of it is learning, like, okay, is this sustainable or not? And how can I make it more sustainable? That's all part of the process too. So for now, I think it's good to get a very robust baseline. And then if you start freaking out later, then you make some changes. That's part of the test of change.
Okay.
Yeah. So when you say that at the end of the PDSA cycle, so if these are the patients she's going to use for her whole PDSA cycle, so she would add the total sum, so 2, 4, 2, 4, 3, 2, 1, 2, 4, and then however many the score should have been, and then divide that by the number to get the percent right care. Is that right?
Well, so it's going to be different for each type of calculation. So averages are, so totaling, right? You total all of the scores over the possible scores. So that would be like, let's say there were 6 patients and the total possible score is 6. So the denominator is going to be what?
There were 6 patients. The total possible score is 6. 6 times 6 is 36.
Perfect. So that's the denominator. Exactly. And then if patient number 1 got a score of 1 and patient number 2 got a score of 2, then yeah, you add all those, divide it by 36, and then that's your average.
So our aggregate is our individual data, and then at the end of the PDSA cycle, the total score is what we're going to use to put on our run chart, or every 2 for the 4 data points.
Well, you're collecting data every, like, you're collecting data every, well, it depends, right? Some of it you're collecting just individual data every 3 days or so.
Right.
But for every PDSA cycle, for sure, you are charting your averages. I mean, that is what the run charts are, is you are putting in your average scores, and then you get a median from your average scores that you're plugging in. But you should be plugging in average scores like fairly frequently, right? Like, what was our average score on April 15th and what's our average score on April 18th? And then you're going to be totaling all those to get your PDSA averages, because your run charts aren't just one dot for every PDSA cycle. It's data collection every few days.
Right, because there has to be 4 points, except for the
yeah, and that's why if you're really good at Excel, you can make it do the work for you.
Okay. Thank you.
Mm-hmm. Did that help, Cynthia?
Yes, definitely. Thank you.
Uh-huh. All right. So, Andrea, your turn. Do you like Andrea or Andrea?
Andrea is fine.
Andrea. Okay.
Yeah. Although I get the other quite frequently, which that's fine as well. So I guess for me with my run chart and things that I like or don't like, I'm kind of neutral because I don't know yet. I haven't used them enough to really be able to say that I think one is better over the other. Are we gonna have time like towards the end of this session to ask general questions? Because I've got just general questions about
Yes.
how frequently we need, because like in the one video, she's like, you're not going to collect data on this all the time.
Yes, because it's different. I mean,
Right.
the questions are what are in the instructions. Like, I mean, for the team ramp, you're only collecting that every PDSA cycle. For the AIM, you're only collecting that every PDSA cycle. But for B and C and D, you're collecting that every 3 days, like at least twice a week, if not more.
Okay. So it was the AIM, the team.
Yeah, because we don't want to annoy your team with you making them do surveys every 3 days.
Totally. And then is it for like the patient surveys as well? Is it going to fall into the same kind of scenario that we only do it like once per PDSA cycle?
For the patients, that's a good question because that's been kind of morphing. But, you know, you have new patients every time. Like, it's not like you're surveying the same patients every 3 days.
Right.
So it would behoove you to do it at least once a week, if not twice a week, because then you can catch things early. Because what happens is when people are spreading things out too far with the patient surveys, they don't find out till the end of the PDSA cycle that something isn't working. And like they're like, oh my gosh, now I have to like do this whole big intervention and I only have 2 days to implement it because the next PDSA cycle starts on Monday, right? And so I recommend with the patients that that you're doing it at least weekly.
Okay.
Because that way you can catch it early if something isn't working.
Okay. Perfect. Cool. Thank you.
Mm-hmm. Yeah, like, so do you have a feeling that like, okay, my B process is going well, or, you know, these things seem to be working, like people are turning in surveys, and like, do you have a general idea of how things are going?
Well, I think that like survey, well, so the shared decision aid.
Tell us your topic again.
Okay, so we'll do. Yeah, we're assessing SBIRT with the unhealthy use of drug and alcohol, and so I can click over so I can share. Doing two things at once here. Can you guys see that?
Mm-hmm.
Okay, perfect. So the shared decision aid, I will be able to, I met with the IT guy today, and I will be able to track this on the computer. So that is helpful. Hide that. And the same thing on the patient engagement score, I'll do that weekly. So I think that'll be fine. Let's see, this is the checklist. We started the checklist. I think this will be fine. And I've got a pretty good group that I'm working with. And so hopefully they're honest. And so that'll definitely morph. But I think that will help us with identifying the appropriate patients so that we're increasing our screening. And so that's my engagement. And then I already am looking at this and I want to tweak some of my graph titles. I think they're confusing now that I spent some time and then I came back to it. The positive screens, it was awesome today. I sat down with Nick and I'll be able to pull this from the data as well. Fortunately, I'll be doing a lot of paper like audits, chart audits, but I can find the appropriate patients that should be screened, and then I can go in and delve into if they were, and all the documentation, like for my case management log, all that data is there. Because unfortunately, some of the charting at the clinics, a lot of the providers take like almost 2 weeks to get stuff finalized. And so I think that's part of one of the issues that I'm running into is, so if they don't finalize and get all their billing and charges done, it doesn't drop, and then we can't track it unless I go in and like physically do it for all the charts.
Oh, wow.
But I mean, we're not huge and this isn't forever, so I can do this now. And then I'm hoping that in doing this and working with a team that they can hopefully change some of their data searching processes so that it can just be on the reports, because they're amazing. They do weekly reports on all of our productivity and meeting whatever goals that they've set for the clinics. It's like, I don't like this one. I've got yearly screening with the BHS6. I don't know if I really like that title, because we're looking at the percent of positive screens.
Yeah, so it would be, because this is your, yeah, so that's exactly right. The title would be screening positive for substance overuse, or however you want to phrase it.
I was trying to make it, person friendly when I was going through making my titles, but I think I just made them too broad. Like this one, patient screen with BHS6, which I could use it for that one, but this one just isn't specific enough, so it just is misleading.
Yeah. And are your numbers looking good? Like you're getting positives, and like you're getting 6 positives a week so that they can receive a brief intervention and whatnot?
Yes. Well, yes, there are positives. What I've done is I've kind of tweaked it a little bit. So there's 4 clinics that I cover. And so it's just going to be too much to launch this at all 4 clinics at once. And I don't see annuals, and I don't see new patients in the position that I work. So I'm really relying on all the teams to do this, with me just kind of facilitating and organizing it. So we're doing a smaller scale, but yes, there are positives that I'll be able to go from and look at. The one thing that on my case management log is their education. Like, what are we doing to provide the care for the patient? Are we doing follow-up, phone calls? And that's one thing that I've been able to kind of identify with the clinic, is that they haven't really thought about that yet. So some of this data that they're starting to collect, they're just looking at, are we doing the screening, but they're not looking at anything else. So I've been able to generate some education for patients, and I'm setting that out in the clinics, and I'm keeping track of those. And at the end of the week, I'll tally up how many are being used, to see if it's a positive tool for the patient's education. Yeah. I don't know. Do you have any tips, pointers? Because I said I don't know yet to have something that I identified.
And your goal came from, looking at data that said this is about the prevalence of people who are overusing alcohol.
Yeah.
Great.
I remember, I think you had talked about on your video when you talked about it, is like how many C-sections. It's not like we want every woman to have a C-section.
Exactly.
And so, yeah, I kind of searched, and that's what I found as what was the most, that was a common amount of patients that were positive.
Great.
Yep.
No, I mean, I think that this looks good. It's just, yeah, like if you feel like things are going well, then they're going well. But if you, I guess, is there a specific roadblock that you'd like some advice on? Or an anticipated obstacle that you might be coming across?
Honestly, I don't I don't know. I wish like you guys would. If I wish it was like next week, and you could have that question for me, because then I would probably have something. But right now, I don't. I mean, today was a good day for me. I had a meeting with some of the upper management, and then I went and sat down with the IT, and that was helpful. And honestly, for me, and just the way I think, putting all this together on these run sheets, the charts, was helpful because it gave me kind of a bigger picture. Like I was telling somebody, I kind of wish I would have seen this before, because it just gives me direction of where this project's going. Where in the past, we're kind of building up to this point, but I felt like I was walking through fog and I didn't really know where I was going or why.
Okay. Is it starting to come together?
Yeah, like I said, sitting down, working on all these Excel sheets was super helpful. Like I said, it gives me a visual and to kind of like something to, substantial that I can say, okay, this is what I need to do. This is how it's going to look over the time frame. My biggest thing was I just wasn't sure on some of these categories, like how often we were having to assess them. And I wasn't sure if you look at my time frame. So I'm kind of picking, my work week is essentially Tuesday through Fridays. So I was taking Wednesday and Fridays of every week as my kind of point collection days.
I think that's great.
Okay. Perfect. Cool.
Yeah. Okay. Oh, and just so you guys know, because in case there's some anxiety about that, I will be going over the PDSA workbook with you before the end as well, because I know that can be confusing to people.
Oh, good.
Yeah. All right. Thank you, Andrea.
Thank you.
Andrea.
Yes.
How's it going?
Good. Is my screen sharing here?
Yes, I can see it.
Okay, okay. So today I think went pretty good. Get on my so I don't know. I feel like my run charts are as okay. I don't my team I don't know where this goal 11 came. What did they want? This doesn't look familiar. Like I don't know what I put or how I messed that up. I'm not sure. I'll have to revisit that. I don't know, but so that's weird. But
so, what are your gaps? What are your team engagement gaps? Because this run chart says that there's no gaps, kind of.
Yeah, I'm not sure. So so when I did like the team engagement, I wonder if I should pull up like my questionnaire, but think about that.
Yeah, pull up your questionnaire.
It's gonna be easiest to do that. Here. I remember where everything's located now. It's kind of. At first, I felt like you kept telling me you'll want everything in one place. You want everything in one place. And I'm like, oh goodness! But now it's becoming more clear what you were talking about. I have faith you knew what you're talking about, but now yeah, be more clear. Okay. There it is. So, but really it was like communication issues within our team and education. Like some of them felt really confident on knowing the guidelines and some people really didn't feel confident. And you think, well, just the providers have to know the guidelines. Well, really the whole team did. So like front desk, when they're scheduling the appointments or something and somebody's like, oh, I need my annual exam. Like, well, do they need, what do they really need when they need that? So there is various different gaps. So it when I look at the whole survey, the average was 80%, but then per individuals, there's big ranges. So I think, this is the one that I'm kind of the most like, I'm not really sure I don't know what I'm trying to say about that. But And I think like just team engagement overall is going to be the hardest thing, just because it changes so much. We have so much staff changes, especially our front desk. And
Is your goal 80? Is the 11 and the 80 flip-flop?
I think it was, my goal was actually 90. I don't know where the 11
Oh, okay.
So if that looks better. Like I wanted to be.
So what, how would you verbalize, like, okay, so is this 80 from that most recent survey?
Yes, the last survey.
And how could you, what do you guys think are other questions she could ask to identify further gaps based on what she just said? Because I'll tell you right now, Adria, if you don't do it now, you're going to have to do it later. So you better do it now. Like you need to identify the gaps for sure.
Yeah, for sure.
Yes.
So the education that you're speaking of, is that how they're supposed to use the tools that you have?
Well, the tools that I have, like, I think they're able to use them fairly well. And, you know, just this morning, like, you know, like it went pretty smoothly, the tools, like how to use them. But yeah, that wasn't seem to be the issue. It's more like, I'm more worried about like, how am I going to get them to come to team meetings and improve like the team, just the, like, I don't know, we get along really well as a team already. Like we're kind of the clinic that everybody wants to work at because we get along pretty well. So
is it the satisfaction score that you're worried
the
about?
satisfaction, that's my balancing measure, is job satisfaction. Like, am I going to ask them to do too much and then they aren't going to want to continue? You know, like, is it going to be overwhelming? So,
Say again where your gaps were at in your team survey or your engagement survey. What didn't they feel went well as a team?
yeah.
Sorry, I was trying to catch it, but I wasn't.
No, it's okay. It's okay. Like,
I wasn't tracking. I apologize. I was trying to track.
it's, yeah, I've lost myself in the moment. So let me. I don't think this is the right one. Let me see. I tried to label them so they made sense to me. It doesn't make. I can go.
Where are your results for these?
Well,
Like,
that's what I had them right there. No, that's exactly
Oh, okay.
it. Like I had my results and
oh, okay.
I didn't think they were that buried, but now it feels like they're buried in stuff. And I have it on a Survey Monkey.
Okay.
So I think that's probably, but I printed them all on a form and I thought it wasn't that buried in papers and filed correctly, but yeah, I don't know. I'll look into that. I think I'm spending a lot of time on trying to pull up my gaps, and I do have them somewhere, and they're just getting a little bit rummy. But so I don't know. We'll just come back to that. But yeah, so I feel like definitely need to double check on that one. But so like the utilization of my patient engagement survey or a patient engagement tool. So by like that one, is like right now nobody's using it, so that would be like the shared. And I'm thinking now instead of patient engagement tool, I should probably just have shared decision aid.
What do you guys think of the operational definition for the y-axis?
So like I don't know.
Oh,
So
there it is.
utilization, like it should just be percent. Because I just like, well, it doesn't need to be utilized on men if I'm doing cervical cancer screening. And it doesn't need to be utilized on women less than 21. So that's where I got for patient meeting screening. Like, so it's, I guess I put screening, but I don't know if it's really a screening. So I have this like algorithm to identify like because we have our health maintenance, but it's not, that kind of says like, hey, PAPs are due every 3 years unless you've changed you've modified it in some way. So, but for instance,
Can you clarify for everyone what your topic is again?
It's cervical cancer screening right care. So
for all women?
For women ages 21 to 65.
Okay. So how could she phrase this operational definition so it's not confusing?
Women.
Would it just be percent of tool utilized?
Yeah, because you don't need to explain here, you know, that, I mean, it's obviously only going to be given to people who should have it, right?
Mm-hmm.
So simplify that. So the percent of tool utilization or whatever. And then good, like the title's good, utilization of patient engagement tool. So what I'm confused here, this is a patient engagement tool. Okay, no,
like yeah.
Anyways.
Yeah, I think, yeah, it's.
And then, so why don't you think this is getting used?
Well, we don't have anything. So baseline, there's not been anybody using it.
Oh, no, I thought you said that your tool was not getting used.
No, I think the tool it hasn't been used, but no, the tool got used effectively this morning. I know that, yeah, it's getting used.
Oh, okay, cool. Yeah. And I know it's kind of tricky because we're so early on, right? Like this is right at the beginning. But trust me that a lot of people were saying when we did it towards the end of PDSA1 or in the middle, people were like, oh, we should have had a meeting earlier because I had so many questions about like what I was supposed to do. So I know it seems weird that we're doing this like right at the beginning, but it is also because we know that you have a lot of anxiety potentially about what to do and want to make sure that it's going to go okay. And we just want to make sure that you're set up so that you don't go 10 days doing something wrong.
And then I'm really grateful that we're doing this today.
And so, yeah, so, you know, I think we really need to focus on your team engagement because that needs to get identified now.
Yeah.
So, pull up your questionnaire, even though you can't find the results. Pull up your patient surveys again and leave it open so that all you have to do is click on that window and not have to search for it every time. Yeah. And then, so start off at number 1. Yeah, so we don't really care about these things that we don't like have
I kind of wanted them to feel like they're getting like number 1 to me was important, or I was feeling like it was important.
Yeah.
Right now, that like I think that one scores like about a 3 or something.
Okay, well that's good. So keep that one, right?
Yeah,
and make
sure.
I
feel like that one's good, and especially because I'm feeling like I'm trying to ask for feedback, and I want to make sure that they feel like I have team buy-in. So,
so let's decide what you're going to keep and what you're going to toss. So you're going to keep number 1.
Maybe communication skills can be taught. Like, I don't really know how I'm going to be able to address that anyway.
Yeah, get rid of that. Maybe number 2, unless you feel like you can really impact that with your project, you could ixnay number 2. Where else are things like perfect? or near perfect? Like, get rid of number 6.
And then I just use my, if I get rid of these, then my baseline will just be like what the average was without these questions.
Exactly, because then you're going to have a more appropriate baseline. I would also get rid of number 5. Yeah. I would get rid of number 5 and maybe number 4. Let me see. Yeah, get rid of number 5 and number 4. And then what you're left with are things related to your project and a gap that you had identified about feeling like their opinions matter. And so your team engagement process, like your meetings or your huddles or whatever you're calling it,
okay,
are going to involve.
You blocked out that last sentence. I didn't hear what
you
said.
Sorry. Let me turn off my video again. So the team engagement huddles or meetings, those are going to include an area where people get to give you feedback so that they feel heard, right? Because you're hopefully going to increase that score, and then you're going to implement their feedback because we want to improve that score for that question on number 1, right?
Yeah.
And then so you're going to have a much better baseline. So what I want you to do is remove all those questions, get your new baseline, and put that in your run chart. Okay.
Perfect. No, that sounds better. Yeah. And then like I added question 13, but that wasn't in my base. You know, my baseline started at 8. Should I not do that one? Because I'm doing the meetings during lunchtime because there's no other time to have a meeting, so it's voluntary. Like if we all do it lunch. I've just been providing them lunch every time.
I think it's good to have. I mean, I'm sort of flip-flopping between making that an open-ended question so that, like, if you decide to toss it, it doesn't affect your scores.
Yeah, that's what I'm worried about. Okay.
Yeah, so maybe pull it out and have it be like, and just have it be, what suggestions do you have to improve? Because if they're like, everything's awesome, then you're good. Or yeah, like, yes, no, blah, blah, blah. Yeah, no, I think that's good. Leave it there. Okay, cool. Does that help? I think that was.
Yes, no, thank you. I don't, yeah. It seems so much clearer just going through that. Thank you.
Mm-hmm. And just so you guys know, like, your feedback, we really do incorporate feedback at Frontier, even though it seems like everything is so crazy. Believe it or not, it was crazier 10 years ago in the DNP program. So already the team ramp is different because we've seen how frustrating it is, and like, why are people asking these questions that make no sense? Like they can't do anything about it. So your feedback has been helpful, and the next cohort is benefiting from it. So, all right.
Yeah. And then,
okay. And then, anybody else? Did you have more questions, Adria?
No, I don't. I mean, I got really confused on these other, like, not these ramp parts, but oh goodness.
Okay.
So I've never used Excel before this, so this is all kind of challenging.
Oh my God, me either. And thank God our class president was like an Excel expert, so she like helped us all. It was amazing.
So I don't know, like, if I have this aggregate stuff, I don't know that I did that right or not, but I don't know that it
Let me see.
at this point. I just try to label things how I thought they should. Oh, where did it? Here, sorry.
Yeah,
these are my questions. I'll take out the questions and then just fill them in, like from.
No, I would leave the questions there, and then you're just gonna have the answers, because what you want to do. This is a good question. So, do you guys see here? There's all the questions. You're gonna want to average score for each question at the bottom, right? So that you could say, "Oh my gosh, our scores for question 3 are really low." And then that way, so it's just an easier way to identify which areas you could use a lot of improvement on. Okay. So you're going to have average scores for each question and average scores total.
Okay.
Now
then
you're
I'll
only
take this-
charting, you're only charting the average team engagement score on the run chart. But for purposes of tests of change and run chart and aggregate data analysis, you want to look at each question and say, ooh, what's my average score for question 1 and 2 and 3 and 4, so that you can identify where your scores are really low and how you can improve the specific areas, not just like team engagement scores are low, how can I improve them? You're analyzing aggregate data to make educated tests of change.
And did I understand it correctly on these, especially the patient engagement surveys and the team engagement surveys, that if we find that questions like we're doing really well on, we can get rid of, or there's something else we want to measure, we can add it in as we go along? Is that right?
You should already have a good team or patient engagement survey that has gaps identified that you have lots of room of improvement for. So you should only have to change your survey if along the way you reach your goal.
Okay.
Because
Like,
Mhm.
like for some reason, they decided that they didn't like the title of my patient engagement survey, so I'm going to have to change the title. That's not a big deal, right? They
Right.
don't like how I worded the title. Okay, that's not going to affect anything.
Yeah.
Okay.
Now, if you are scoring perfectly on something, the only reason that should be in there is just to keep tracking it and make sure it doesn't go down, right? Or making sure that the important part of the year that you're trying to affect, so you leave it in there even though you're scoring perfect.
Okay. I just thought that I'd read.
It's important it should be in there because scores can drop.
Okay. I just thought that I'd read that somewhere that, we might find that there's something we need to just measure for one cycle because it was not going well, or we just needed to see how we were doing in a certain area. Maybe I misunderstood.
No, that's right. But that's for
Okay.
that's for information gathering purposes and data analysis, not necessarily your like average run chart scores.
Okay. Okay.
Yeah. Because like, what if you just have a theory? Oh, I wonder if we need something in Spanish. So then you're going to do a little survey, right? Hey, do you guys want stuff in Spanish? And then so you'll be asking about that for one cycle. And if people are like, hell no, and then you're like, okay, then we don't want to do that for the next test of change. Yeah.
Okay. Okay. Thank you.
Now, yes, let's say you implement this amazing intervention and your scores are awesome by PDSA-2. Then yes, you need to you need to identify new gaps and continue to improve. That's why when people are like, oh my gosh, our scores are so low, I'm like, that's awesome. You have so much room for improvement. I can't tell you how much people's brains are spinning when things are so fantastic. I tell you, some of the students that have the hardest time are ones that believe their practice is perfect. Oh, we do everything so well. We all get along. We all love each other. Everything is so efficient. Our patients love us. There's nothing to improve. They struggle in a DNP project because they're not thinking out of the box to ways that they can further improve. And they're so limited by this belief that everything is so perfect that it's really hard for them to come up with gaps and tests of change, okay? So what I'd like to do, well, first of all, what other questions are out there before I go into the PDSA workbook?
Can I just ask one more on my aggregate C then?
Sure.
So my C ramp is just using the, is so there's, the process part is this algorithm getting used so that we can identify when people aren't that, like, for instance, the first patient in one of the providers, when the MA rheumatoid, she used the screening tool and the health maintenance had been turned off for her for PAPS because she had a hysterectomy. Well, yes, she'd had a hysterectomy. She had a hysterectomy for cervical cancer.
Oh my gosh.
So she screened positive on my, right? Like, so I was like, see, that's why I made this algorithm. And I felt really good about it. So
awesome.
So my process was used, and you know, and then the outcome was that she screened positive, so that's good. But then on this aggregate, on my aggregate paper, and so I have 2 columns, but I'm not sure, like.
So this
So,
is
like,
for
query
this
screening
is
tool.
for,
So this is my. Yeah, I don't know. I just feel like this isn't right.
this is for which chart? Because I can't see the whole. Is it for C process?
Are we supposed to have aggregates for the process and for the outcome? Is there supposed
Yes.
to be 2 different ones?
Yes. Well, not
Okay.
no. Sorry, not necessarily 2 different ones. Just all your data needs to be on the aggregate data sheet.
Of the
So
aggregate.
what is?
So I can put my
So
process
what
and my
is?
outcome. So I just need to be, so 1 column for utilization for each patient and 1 column for their, how they screen.
Like I would just say for each patient that qualifies, like, was the tool used? Yes or no? And then, like, what's the other thing you're trying to measure?
So yeah, what was it used? Yes or no? And then did they screen positive?
Did they screen
Yeah.
positive? Yes,
Yeah.
exactly. Yeah.
So,
So, and then how do they screen positive? Is it a score or is it what?
It's just like, here, I have my algorithm, you can see here.
Yeah, show us here.
Yeah, so it's like, oh, they're not female, then they don't, obviously, that we don't even,
Right.
that's just kind of a funny thing I put there for humor. But like,
Right.
okay, so they screened positive, like, because she had a history of cervical cancer. That was there. Somebody
Right,
screened
but then
positive,
you
they
also
have a
need to
history of abnormal. And so really screening positive is just means, for me, it's that they need to get it in the case management log so I can see, are they really current or not?
hold on.
That's what the screening
So
positive
your
really
algorithm
means.
needs to be very, so I'm just talking about consistency here, you guys. So your algorithm needs to say female or trans male age 21 to 65. Okay? Like,
Yeah.
just be really clear about that. And then you're going to do history of hysterectomy with cervix removed. Yes, no, history of cervical cancer, boom, boom. So, how are you identifying after they do this if they screen positive or not? Are they circling something, or is it part of the
They
dot
just put it,
phrase?
so I have this dot phrase, and when they put in the dot phrase, it says that they used the tool and then what the outcome was.
Okay, perfect. I would, for the purposes of your project and dissemination and sharing it and spreading it, put what the dot phrase says there so that people who want to replicate your project know what the dot phrase says. Okay, and then
And then the
okay,
MA is
good.
just supposed to tell the provider what the result is, and then the provider can decide how it needs to be managed. Yeah.
Okay,
So
and
then that gets entered in the case management log, and the health and maintenance gets updated.
okay, and then the provider enters it into the case management log.
And then
Okay.
I compile all those.
Yeah, very cool, very cool. Okay, so go back to your aggregate data sheet. And yes, so one thing I recommend is to have a way to easily identify who screens positive, you guys, in your aggregate data sheets. If you're doing a screening type of project, you want to be able to like flag it red or something so that when someone goes back and looks, they're like, oh yeah, like, because then you can see, oh good, yeah, we have 6 positives a week. Our numbers are good, our ventures are good, blah, 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 right? So yes, you're going to have one column for cervical cancer screening tool utilized, yes or no, and then another column for screened positive, yes or no. But, okay, so I wouldn't have it be
And
screened
so, like,
positive. I would just have the column be like, and add a column for results, positive or not. And then they get a score for using the tool. They get because this isn't your case management log, right?
No, I have a case management log separate from.
Yeah. So you're not really like
this just tells who gets into the case management log.
Yeah. So basically they can get like a score of like your results are going to be percent who screened positive, okay? For this. Does that make sense? So your C outcome is going to be this column. Like you're trying to find out. Oh, sorry. No. That's not what I meant. I meant that's what this column's for, is to capture the percent that's screened positive.
Screening
So
results.
it should just be screened positive. Yeah. Like, did they screen positive, ? And then you'll have at the bottom your percent that screened positive, right?
Yeah.
And then your first column is your process outcome, right? What's the percent of, so here you have process and then you have outcome in your one aggregate data sheet, okay?
It just felt kind of like it was simple because there was only two columns. But
Yeah, you're very lucky. Yours is simple, unlike Cynthia's.
Oh, I know. I saw hers and I was like, oh my gosh, that would give me a headache.
Yeah.
Okay.
And then,
and I feel like this one.
yeah,
That's my case management.
yeah. Like, and then for other people, because, you know, part of this project or part of the program is not just learning how to do your project, but other projects. Like, you know, for other people who are doing depression screenings, they may have various degrees of depression. Like, did they screen positive for mild, moderate, or severe depression? Like, so their screening aggregate data form will be more complicated too. It won't just be screened positive, but it'll be for what level of severity, and they'll be calculating what percentage are screening positive for mild and what percentage are screening positive for moderate or severe, because the interventions are different for each of those. So that's just to give you an idea of what it might look like in other projects, okay?
Thank you.
All right. Any other questions before I dive into the PDSA workbook? All right, let me... All right, I'm going to screen share. Okay, so if you look here, so you guys have all turned in your plan. You'll be getting feedback about that later this week. But in general, some of the most common errors we see, and you should definitely take everything I'm saying seriously, because you will get points off if you don't do what we're asking. So the test of change for your first plan is just your core intervention, right? So this is going to be like team huddles or team meetings. For patient engagement, it's going to be like shared decision aid. But for subsequent ones, you're going to be changing those. That's hence test of change. And then you will put in instead like providing food at team meetings, or for patient engagement, you could be like providing infographic with shared decision aid, okay? You're gonna wanna put those in red, and then when you write your learning objectives, you need to use your core intervention or test of change and highlight that specific phrase again in red. So learning objectives, and this is very important, learning objectives are not observations. And they're not just, I want to know if team meetings are helpful. That's not a learning objective. A learning objective is a higher level of desired learning about a specific process. So it's not just like, never put as a learning objective, will my test of change work? Fill in the blank for test of change. Will just shared decision aid improve patient engagement? Do not put that, okay? So for your learning objectives, you're gonna wanna put like, will having lunch hour meetings help people feel more, have their opinions feel more valued because we're including opportunities for feedback? Like, it's a more detailed inquiry into your specific core intervention. Or like, will having the group meetings improve confidence in discussing cervical cancer screening, because we'll be doing role plays, and role plays have been shown to improve use of shared decision aids or something like that, right? Like, so it's not just, you know, will my tool work? Meaning, will it improve team engagement? So don't say, will shared decision aids improve patient engagement? Will screening capture more people who are depressed? That's not what we're doing here for learning objective. We're wanting to know, like, what is a higher level analysis of your core intervention or test of change? Okay? Now for your predictions, similarly, don't just put, I predict that team meetings will improve team engagement. No, that is not a prediction. You want to predict, you know, if you look over here, like, so with the predictions, you're wanting to put in something higher level, like, okay, actually, I have another tip. When you're doing your learning objectives, start off the phrase with I will learn if, or I will learn about. You need to start with I will learn. That will keep you from making it a prediction or making it something else, right? So just remember to use the phrase like I will learn. That tends to help with learning objectives. Now for predictions, you are wanting to make sure that you are assessing what is going to happen on a deeper level other than another version of I predict my intervention will work. Okay, so like if you're doing it during lunch hour, like I predict people will attend because I'm providing food, which is a strong motivator for attendance. Or I predict patients will enjoy the shared decision aid because I use lots of infographics and those have been shown to help. And a negative prediction would be like, but I predict they might not actually use it because it's really long. And maybe it needs to be more efficient. So those are higher level types of predictions other than will it work or not work. You're needing to answer the question why. Okay, so don't just put your prediction like I think it'll work. Tell me why. And then that will bring it to the next level. Okay, so I predict this because, and then answer why you're predicting that. And that should keep you out of the simplifying or oversimplifying role here. For your hyperlinks, don't just hyperlink like HTTP, www, like it should say do file and hyperlink to the file. It should say run chart file and hyperlink to that. It shouldn't be just the HTTP thing, okay? And if you need help with that, you could ask IT about that. So learning from the predictions, positive and negative, that's like I learned, and again, you don't want to say I learned that team meetings improve team engagement. That's not what we're talking about here. What did you learn? Like, oh, I learned that infographics do work, or I learned that role playing does work, and or I learned that role playing was annoying for negative. Role playing was annoying because it took too much time and then we went over or something, right? It's something that you learned that will affect future things. Like what are you going to change because of your learning, or are you not going to do it anymore? Or what's going to happen? Your run chart, you're going to be learning, you're going to be looking at your run charts. So you're going to open your run chart and say, hey, what is this? If I'm looking at this run chart, what am I learning here? And you're not just saying, oh, it looks like things are going really well. It's like, oh, it looks like when I did this test of change, things really improved. Or, oh, I'm looking at my run chart and it dipped unexpectedly because we had 3 providers call in sick, right? That's showing me that you're analyzing your run chart and that you're not just like, oh, I don't know why it dipped there. I don't know why it went up there. Like, show me that you're analyzing your run chart. And then for the aggregate data, we just had an example of that, right? Like, look at each question and tell me like, oh, I'm learning we're doing really well with cervical cancer understanding, but we're not doing so well with helping people feel like their feedback is valued. Okay, so that's where you're analyzing your aggregate data. And the reason this is important is because your ACT for your next PDSA cycle should be based on your learning. So let me see here. So your ACT, which is just one thing, right? You just need one test of change. Your ACT should be based on something from here. It's not just out of the blue. Your ACT is like, okay, I learned that having food doesn't really matter. People still didn't show up. So I'm going to do a survey to find out what would help motivate people, and then I'm going to implement whatever feedback I get. Or I'm going to, or I found out that the patient survey or the patient shared decision aid was too long, so I'm going to simplify it and make it only 2 pages. Boom, that's all your ACT is, and it's based on something you learned from either a prediction, a run chart, or aggregate data analysis. Literature, you know, sometimes you don't have data here, but you have data from the literature. So you're like, oh my God, I have no idea why the team engagement scores are not going up. And I've tried everything and I'm not getting any feedback. So then you can look in the literature and the literature will tell you, hey, like you should try role playing. And you could put in here the citation APA format for the role playing and then put here, add role playing to team meetings. You don't need that for each one, but we do expect to see at least one literature citation. The literature citation could also support one of your learnings and one of your tests of change that you're going to do, and just give additional support for it, okay? Then you're going to also submit the plan portion for PDSA 2. So when you turn in PDSA 1, you're going to have PDSA 1, all of this complete, and the plan portion of PDSA 2 so that we can make sure you're on the right track with what you're doing in PDSA 2. So just this section here. So this would be not your core intervention. You could put your core intervention down here if you want, like team meetings or something. But here, it's going to be, what are you doing differently? And you're going to put it in red, and you're going to put it in here as well. So if you're going to start doing role playing, you could put like add role play, and then here, like, I will learn if role playing will provide practice to go over the shared decision aid with patients. Oh my gosh, my typing is horrible right now. And lead to more confidence in discussing it. Whatever, I'm not even going to try to type anymore. Okay, so and then you're going to have your predictions, a positive prediction, a negative prediction. Oh, it looks like over here that was removed. A positive prediction is like something that will happen and something that you think won't happen. Right? Like, oh, I predict the team members will love role playing. I'll predict that the nurses will hate it because they're already too busy and need to use their lunches doing something else, right? Don't forget, this prediction, you're answering why you're predicting it. The other common thing that I saw was people putting in like, I predict scores will increase by 50%. How do you know 50%? Like, so don't just put like, okay, I predict it'll increase by 50% without explaining why you think 50%. Like maybe because literature shows that when you start role playing, scores increase by 50%. Like at least you have to explain why you think it will increase by that. If you can't back up a number, don't use one. Just say, I think it will improve. Okay? Because sometimes people think they're seeming all smart by like adding in a percentage, but you're not, because you're not basing it on anything. So it should be based on something. We will be giving you lots of feedback, and that should be expected, right? Because we're trying to help you make this as successful as possible. So don't freak out if you see a lot of feedback. Be like, yay, I have a lot of feedback, and this is going to help me even more in PDSA 2. The other thing you have to remember is each PDSA cycle has progressively more points. I'm going to see if I can do video. Let me know if I'm cutting out. Each PDSA cycle will have progressively more points. So you shouldn't freak out if you score poorly in PDSA 1. It's only worth like a little amount of points. But we do expect that you'll get better at doing these throughout. The biggest reasons people bomb these PDSA workbooks are they're not listening when we say, don't just say, will my test of change work, or I predict it will work. Like, I can't, like, I've had some students, PDSA 4, they're still doing that. And they're like, why am I only getting like this score? It's like, you have to actually incorporate that, okay? The other reason people bomb is their test of change is not based on any data. They're like, you know what? I think I'm gonna do this in Spanish. But they have no feedback that Spanish is needed. They don't even know what percentage of their population is Spanish speaking. They're just like, my next test of change is to do this in Spanish. So it's like you're all of your ACT sections, which are essentially your tests of change for the following PDSA cycle. That's what the ACT section is. Those should be based on data, either from your surveys, open-ended questions, run chart analysis, or aggregate data. The other thing that it could be based on is field notes. Like if you had, like, because you're taking your field notes, right? And you're writing all of these details. Like let's say in your field notes, you notice something. That's data. That counts as data. So even though we don't have a section for it, like under learning from, that could be still put under there, even though it's from your field notes. And you could say, gosh, in my field notes, I'm noticing that the nurses really aren't liking this. And they're not saying anything in the surveys, and they're not saying anything here, but I'm just noticing it in the field. So I talked to them, and this is what they told me, and that's in your field notes. It's not just in your head. You wrote it in your field notes, spoke with RN today, got feedback, la, la, la. That could be contributing to your test of change. But don't just pull it out from anywhere. The other place it could come from, if it's not getting collected in the data you're collecting, is the literature. So if you're stuck and you don't know what to do, you're basing it at least on some literature that is backing up why you're choosing that. But be careful if you're choosing something just based on literature without any data that you've collected yourself, because that increases the likelihood it won't work. Okay? And just another thing I wanted to emphasize is your tests of change, you don't have to wait till the next PDSA cycle to change, because it'll just be painful for you. If you notice halfway through a PDSA cycle that something's not working, change it now to try to improve your numbers instead of waiting till the end. You can schedule a call with me. You can email me and say, Anna, I'm really nervous. Like, I thought this would work, but already I can see it's not. I need some help here. And we can have a meeting, okay? So if you're flailing, reach out early. Don't wait until the end of the PDSA cycle, and be constantly looking at your data to make sure that things are moving in that direction. And I can't say enough how important getting your team on board is. If your team is not on board, can dig deep in that leadership class you took and dig deep in the literature for ways to improve their engagement and get their buy-in, because that will be a huge part of your success. If they're telling you that your surveys are too long, you need to change them. Or if they're telling you the meetings are too long, change them. I had a student that was doing, weekly lunch hour meetings, and it was bumming everybody out. So she changed them to 15 minutes. Like, we don't care how long your meetings are. Like, we want your team to be on board and figure out ways that you're meeting their needs as well, okay? All right. Any questions? Woo! All right. You guys are doing great. I'm so excited. I'm so excited to see how this goes for you.
Can you go back to the PDSA worksheet? I don't understand on the do. I don't understand how to hyperlink files, but hopefully that video will work and I'll figure it out. But on the do, where...
Let me see. Where did I put it? Hold on.
If you can't find it, I can pull mine up right quick.
Hold on. I think I just shrunk it. How weird. Well, anyway, what are you asking about?
Okay, so on the, like where it says do, can I just pull mine up here? I'll just share mine. So I word my question correctly. So share. Well, maybe. Okay, there we go. So on the PDSA, nope, yeah. Oh, no, wrong thing. Sorry. Okay, so where it says do, okay, the do file. So that's like our field notes. And then, okay, I don't understand the difference between the run chart file and the aggregate file. Aren't those all one?
No.
Or I have to separate those out?
What? Okay, so your run charts should have annotations, right? Your
Yes.
run charts have annotations, and you may have events happening that aren't in your aggregate data. Like here in Alaska, we had a 7.0 earthquake. So the Alaska students put that on their run chart. Like, oh, this is why the patient survey process went down, because we had an earthquake. So surveys didn't get handed out that day, or something.
Yeah,
like
no, I understand that, but it's all in one worksheet, isn't it? It's all in one workbook? Okay, I guess I'm confused then.
Run
So I have
charts
to
run charts are your actual run charts. You're looking at your run charts.
So I have to figure out how to separate those out of the workbook.
Oh, they're all in one workbook, but the run charts are separate files from the aggregate data files.
I guess I don't know how to separate them out though. I know it's all one workbook.
You do not have to separate them out.
Okay, so the run chart file and the aggregate data file are all one.
Right. Some students have them separate just because they've got some craziness going on. That's why we do it like that. But
I can just upload my I think I title it my run chart workbook, the whole thing, and that'll take care of the run chart file and the aggregate data.
Yep, if they're both in there.
And then the measurement worksheet is the measurement worksheet that we used from PC740 that we had to upload everywhere, right?
And you updated it if you received feedback last term. Make sure all of your measures have all the updated feedback. Make sure you upload the correct file. Some students make a mistake and upload an old file, and they lose a bunch of points because their measurement worksheet is the wrong one and it's not updated with the correct operational definitions. So, and yeah, you can put that as a Google document and then link to that.
Okay, and the do file, we can just make a table or something and add into it, and then just add that. Or does it need to be?
You should have a template. I think Dr. Dallas usually gives a template for the field notes. Yeah.
I don't know if there was a template. There was examples, but I don't know if there was a template.
Yeah. I guess that's what I mean. Just like follow some of the examples there. Okay. You just want to make sure that you have the date and then your text. And what some people do that has been helpful. So, then make it clear if this is PDSA 1 or PDSA 2 and whatnot. And sometimes people will highlight, specific things that are making them think about a potential tested change or something.
Okay. Can that be just does it need to be a Google Doc, or it can just be a Word doc? I know those are like really specific, but I'm just trying to make it make sense in my mind.
I would do it as a Google Doc because then you can access it everywhere.
Okay, a Google Doc. Okay, and then
why not?
What does the hyperlink summary file? That is where we're starting to write our paper.
Oh yeah, sorry, I didn't go over those. So this,
And then the core
summary-
intervention, sorry.
Oh yeah, sorry, let me go over those. So the summary file is where you are basically writing a summary of that core intervention. So in your first PDSA cycle, it'll be all about first starting your core intervention, right? In your subsequent ones, you are going to be more challenged because you only have a 5 to 6 sentence maximum, and you're going to have to summarize the entire core intervention ramp in that paragraph. So you'll be all having all this luxury, the first one, because all you have to talk about is this one PDSA cycle. But as you progress, you'll be needing to figure out what data am I going to include and what data am I going to leave out. So you don't write everything in there. You write the most significant events. So like, for example, for team, you're not just going to say, oh, in PDSA 1, the scores went from here to here, and this is what the core intervention was. In PDSA 2, the scores went from here to here, and this is what the intervention was. That's not what we're looking for. It is data, but it's an analysis of the data. So you could say, let's say you're in PDSA 3. Between PDSA 1 and PDSA 3, scores increased from 20% to 80%. The most impactful intervention was when we added role playing. That improved, which improved scores from blank to blank. We've been challenged with improving feedback mechanisms, likely due to the unsafe environment for feedback in the past or something. You're analyzing it. You're not just regurgitating the data, but you're giving me an analysis of it. So in your first one, you're going to tell us, okay, after implementing team meetings, scores improved from blank to blank. And the strongest aspect of the team meeting was this, and areas for improvement are this, right? So like that's a lot of information in one sentence. So you can see how actually you can summarize your entire project's ramp A in 5 or 6 sentences. You just have to have that flow. So what I would use is, you know, between PDSA blank to blank, scores increased from blank to blank, with the largest influence being blank or something, right? That's a lot of information right there. So don't just regurgitate data. Don't just, even though it's a summary, don't just summarize the data, but give us an analysis of it, right? Or 2 people unexpectedly quit and team morale went down, which affected team engagement scores, right? Something like that. And so you do that for each ramp, okay? Often people write too much. They're like, and then this one day it was really hard, and it's like, no, just like a summary with good analysis, higher level analysis, okay? 5 to 6 sentences max. And no frickin' semicolons to separate like 5 sentences. Like, no. Actual sentences with like just nice flow to them. And yeah, that means you're going to leave some stuff out. So only tell me what's important. Like if you're like, oh my God, this is my chance to tell this person how to do this ramp right and what mistakes to avoid. That's what we want to hear. Now for the test of change table, very simple. So your first PDSA 1 will just have your core interventions. Team meetings, weekly team meetings, shared decision aid, blah, blah, blah. That's in PDSA 1. PDSA 2 will be added role playing, added infographic, blah, 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 right? Whatever changes you made for that PDSA cycle. These should be 5 or fewer words, ideally. You shouldn't have to go and explain what that test of change was. You should be able to describe it in a succinct way that conveys what happened. Don't just say, updated survey. Like, what does that mean? Like if someone wants to do the same thing, how did you update it? So you could say added open-ended questions, right? Because maybe you weren't getting enough on the Likert scale. Or like what's another example? Or some people say add incentives to team meetings. What does that mean? Like what exactly were your incentives? So just write it out. Like held a prize for who did blah, blah, blah. Okay, so detailed but succinct. All right.
Was there an example of that core interventions table somewhere? Because I found examples of almost everything else, but I don't remember seeing an example of the core intervention table or how it's supposed to be set up.
That I don't know, but you can look. It's basically like PDSA, a column for the ramps, like, A is team engagement, B is patient, C is blah, and D is blah. And then you have a column for PDSA 1, 2, 3, and 4.
Okay.
So a 5-column, 5-row table.
And we're just saying in PDSA, or for ramp A and PDSA cycle, our core intervention was this. For B, it was this. And then for 2,
No
PDSA 2.
No sentences. You just write it in the appropriate box. Let me
So
see.
it's just going to say daily huddle. And then if our core intervention for PDSA cycle 1 for A is daily huddle. And then our test to change for PDSA cycle 2 for ramp A would be changed huddle to twice daily, or huddle twice a day.
Yeah. So, gosh, I wish I could pull up the sample.
And maybe I missed it. I thought I'd found samples of everything and read them, but maybe I missed that one.
You guys see what I'm saying? Like, it should have 5 columns. The first
I understand what you're saying.
Just like A, B, C, D, and what that each ramp is. Yep. PDSA 1 is core interventions. PDSA 2 is tests of change for each one. PDSA 3, like that. Anyway.
Gotcha.
All right.
Totally got it. Thank you. I just was unclear about those.
Yeah, so I'm glad you caught that. I didn't talk about those 2 things. Oh, because that's the other place people bomb is in the summaries. They're just telling me what their results are. Like, I don't care about that. I mean, I do, but what we're seeing here, what we're grading is, notice it's under study. Like, not just can you regurgitate the data, but are you analyzing it? And what are you learning from looking at what happened, right? Okay? Woot woot! You got it. See, your 13-year-old daughter. Don't grow up. This is the kind of.
She says, "Don't grow up, Jenna."
My friend has this 9-year-old, and she's like, she sees how stressful being an adult is, and she's like so not into it. Like most kids are like, oh my God, I can't wait to drive a car and do all this stuff. And she's like, because I'll be like, oh my gosh, you're so smart. Like some adults don't even understand that. And she's like, what do you mean? No, I'm like not anywhere near an adult right now. No, and she's like terrified of it. I'm like, oh, sorry. Yeah, no, sorry. You're still way 9. Sorry. But, okay. All right. Hang in there, everyone. You got it.
Thank you, Dr. Rosoni.
Thank you.
You're so welcome. All right. Remember, reach out if you need help, okay?
Okay.
All right. I'll send you the link.
Thank you.
You're welcome.
Okay. All right. Thanks.
Good night, everybody.
Bye-bye. Good night.
Good night.